been a good journey getting here. I've been in Baton Rouge now about 12, 13 years, and initially I started out bright-eyed, bushy-tailed, and just focused on the usual stuff that I was trained on. A little high blood pressure, some cholesterol, and a lot of what we dealt with was taking care of very sick patients in the hospital. But I realized that the majority of my practice was really geared more to treating people who were just in the early stages of disease. And we had never really been trained on how do you prevent disease. Really, what screenings are we supposed to offer to keep people healthy? In residency, we're all trained to take care of people who are already ill, way into their illnesses, so it was quite a change doing primary care medicine. On that same note, I later became interested in weight loss medicine because so many of the chronic diseases we were dealing with, high blood pressure, diabetes, cholesterol, heart disease, could be prevented and or have their risk greatly decreased with weight loss and exercise. So at the Lake, we started a program called Lake Weight Solutions, which is a very good tool in helping patients get quick weight loss, yet a balanced program and a supervised program that helps you keep the weight off. That goes at least 2 years and beyond. So when I get to that part of the weight loss talk, I'll mention that again. But pass those out. If you don't think it's right for you, you could pass it on to somebody else. That'd be great. Thank you. But the talk today is going to center mostly on what it is that we do to find disease in the general population when patients have no symptoms of a disease. These tend to be very common diseases. They tend to have high risk involved years down the road. And so we intervene early. We try to pick it up. We screen the general population to find the disease, and if it's appropriate, we treat it early before it progresses, before it can cause further damage. We'll also talk about immunizations too. Afterwards, we'll have about a 15-minute time for questions. So there are a lot of different recommendations and guidelines out there for screenings. If you were to go to the web, you would find recommendations from the Cardiology Association, from the Cancer Association, from the Urology Association, from the Gastrointestinal Association. All are a little different in which screenings they recommend and at what ages they start. But what I want to focus on, and I think this is where most of the guidelines are going to be headed, is what the United States Preventive Service Task Force has come up with their list of guidelines. And I want to cover those today that are recommended as Class A or B. A means we have good evidence that this test or screening is effective at picking up disease early. And B means evidence is probably pretty good that it's a good screening test. C, which I don't have listed here, but C means no good evidence one way or the other, and D means they recommend against it. But I really wanted to focus on the A and B type recommendations today, which tend to be less controversial. The first thing that we always do is start with a history and physical exam, because we want to know what has gone on in your health in the past to help us figure out what's going to happen in the future. We want to know what has happened in your family so that we can help predict and determine which screening tests might be right for you. And, for instance, if patients have family history of diabetes or heart disease, we're really going to work with that patient extra hard in getting weight controlled, their cholesterol controlled, their lifestyle in order to help prevent progression so that they don't just follow in the footsteps of their parents. We're also going to want to know about social history. What's your lifestyle like? Do you smoke? How much alcohol do you drink? Is it regular? Have you done any illicit drugs in the past? What's your sexual lifestyle like? So these are all important in trying to determine which diseases might affect you later. On the physical exam part, the vital signs, of course, are very vital. That's why we call them vital signs. Blood pressure is very important because we know that for about every 10 points increase in the diastolic, which is the bottom blood pressure, above 80, and every 20-point increase in the top number called the systolic, that doubles the risk for stroke and heart attack. So blood pressure is a very good screening test for picking up patients at risk. And in fact, we even use the blood pressure of 130/85. If we see that, we even start screening for diabetes there, even if the patient doesn't have any history of sugar problems. That's one of the guidelines we'll talk about. We're going to listen to the heart and the lungs after we look at the head. We're going to feel the stomach for any abnormalities or growths. We're going to feel the thyroid. We may or may not check the prostate, which we'll talk about later. We look for swelling. We look for skin cancers. And this is just the standard exam that you will get and should get once a year with a primary care doctor. The first set of screenings that I want to talk about is cardiovascular, because cardiovascular disease is the #1 cause of death in the United States. And there's a large part of it that we can prevent. So the goal is, of course, to start screening those patients, particularly those over 35, to help prevent progression to heart disease or prevent heart attack. We have a formula that we typically use called the Framingham Formula. It was derived from a study called the Framingham study. And what it does is it allows us to predict what is the chance that somebody's going to have a heart attack or have significant heart disease 10 years down the road. And we use things like smoking or high blood pressure or diabetes. We use the cholesterol. We use blood pressure readings in that calculation, and we come up with a number. And if that percentage is moderate to high risk, and anywhere, if you have a 10-year risk of getting heart disease, it's somewhere around 15% and above 20 is high, 15, 20 is probably a moderate risk for the 10 years. Those are the patients that we're going to take extra time with in considering these screening tests for heart disease. There's also been some things talked about as far as, do we start medications very early before people get the disease? And the medicines that we would typically use in that situation to prevent cardiovascular disease may be aspirin or a statin drug, which helps lower cholesterol and prevent heart attacks. Or do we treat blood pressure a little earlier rather than letting it go on? And this really all depends on what that risk score is. So if somebody's got a much higher risk, we probably would look at using an aspirin, using a statin, getting more aggressive with blood pressure control. Where if somebody who had a very low risk, based on that Framingham score, we might just say, all right, let's work more on lifestyle intervention, let's check you back in about 6 months, maybe we'll repeat it in a year. So that's kind of what guides us and how aggressive that we are in treating patients, because remember, every medicine's got a little poison in it. Even an aspirin can have side effects. 81 milligram aspirin, I see a lot of men walk in taking it that don't need to be taking it. Those at high risk potentially do need aspirin, assuming that they don't have too many risk factors for gastrointestinal problems, ulcers, bleeding ulcers, those type of things. High blood pressure is certainly a big risk factor for causing wall stress on these arteries, which can lead to cholesterol getting into those walls and forming plaques, which can lead to a cascade of events that increases inflammation locally in those arteries, and that can cause later rupture of those plaques and stroke and heart attack. So as I mentioned earlier, just a rise of 10 points on the bottom number or 20 points on the top number can double your risk for stroke and heart attack. So we would want to be aggressive in those patients in getting their blood pressure controlled, particularly the ones with the higher risk of heart disease of the next 10 years based on that Framingham data, or if somebody already has diabetes at that point or known heart disease, we would be more aggressive with those patients. Now, high blood pressure just defined as a number greater than 140/90. And we usually like to have it at least 2 times on 2 separate visits. But a lot of times, patient comes in, it's their first time, and maybe they can't get back to us, so I often will make that judgment and check it again during the visit. If it remains high, I'll probably go ahead and treat them if they haven't already done some lifestyle changes to help lower the blood pressure, such as walking daily, exercise, reducing salt in their diet, those sorts of things. Now, they recommend screening about every 2 years for the person who is without any real risk factors. However, if you're 50 and above, which this talk is more geared to you, then we would probably screen every year for that. Maybe even more often, depending on which illnesses you have. One of the other things that we like to screen for is aortic aneurysm of the abdomen. Now, the aorta is the big main blood vessel that exits out of the heart, goes down the back side of the body, all the way down into the abdomen and breaks off into the legs. And I'll show you a picture of that in a minute. It's recommended that all men between the ages of 65 and 75 who have ever smoked should go ahead and get a screen. Usually it's done with an ultrasound, which is pretty easy to get. There's some other ways of doing it, but this is the most common way of doing it. Because we know that if the aneurysm is a certain size, if it's greater than 5.5 centimeters, then patients benefit from early intervention, getting the aortic aneurysm fixed. Most aortic aneurysms are asymptomatic, meaning that you're not going to have abdominal pain or back pain. Some people come in with blood pressure very difficult to control, and that makes us want to look further for aortic aneurysms or artery problems to the kidneys too, but that's an important test to get. If you haven't had it, please talk with your doctor about it. The other reason we would do surgery on an aortic aneurysm if it's growing rapidly. So even if somebody has, say, a 4 centimeter aortic aneurysm, if it looks like it's growing half centimeter to a centimeter every year, well, we'll probably get more aggressive about that too. And there have been some really good advancements on treatment of the aorta aneurysms in the abdomen. We don't really screen for the top ones. We look for the abdomen ones, which are the most common. Here's an example. Let's see if I got a pointer. Well, yeah, here we go. So this is, okay, so this would be normal. And you see how it runs up out of the heart, down into the legs. This is what it looks like. The branches off to the intestines, to the kidneys. But right here, you see there's a big balloon. And that balloon is a weaker wall, and it will dilate slowly over time in a lot of patients. Smokers are really at risk for this. That's why I screen, and it can rupture. Some of the presenting symptoms would be, when somebody has symptoms, is back pain that tends to be worse sometimes at night, and it's not associated with bending over or lifting or twisting like a musculoskeletal problem would be. But again, most patients have no symptoms of these until they rupture. And when they rupture, there's a very high chance, probably 80% plus die if these things rupture. So that's why we like to pick them up early. There has been also other arteries that have been looked at in the past, and this is about the carotids, which are in the neck, right here. And the theory is, just like plaque can build up in the heart and the heart arteries can get narrowed, so can the carotid arteries. If there's enough decrease in blood flow, people can start to have symptoms of lack of oxygen to the brain. So they may have strokes, they may have those mini strokes, or what we call TIAs, or transient ischemic attacks, where somebody may come in with a numbness of the face or hand, or loss of vision of one eye temporarily, slurred speech, some other neurologic changes. So it is, and it has been in the past, an important area that we thought of that should be screened. However, this United States Preventive Task Force Service does not recommend routine screening for carotids at this point. But I bring it up because a lot of patients come to me with scans that have been done outside and around the community, but it's not recommended at this point for asymptomatic patients. However, if you're having those symptoms that I talked about, numbness, tingling, loss of vision, slurred speech intermittently, that would be somebody we would want to check. Or if people have known vascular disease, we probably want to look at the carotids there too, but that's not a screening test in somebody who is otherwise healthy or asymptomatic. This is probably about a cause of 15% or fewer of the strokes. And the reason, I'll just go back real quick, the reason I wrote that it hasn't been shown to be beneficial for asymptomatic patients, because if we did find a blockage in somebody who does not have any symptoms, let's say they had an 80% blockage, and it really is about 80% blockage of the carotid, that would need to occur before we'd start to see symptoms generally. I know this sounds like a lot, but our interventions for carotid artery disease, called a carotid endarterectomy, where they actually take out all the blocked up part, there's a risk for stroke in that too. Probably about 3 out of 100 patients who had that surgery can have a stroke. So obviously we don't want to just look at everybody and say, oh, you've got 80%, let's do a surgery. They're a risk. So that's why this test is not recommended routinely for asymptomatic patients. Also, what about stress testing? Walking on a treadmill, looking at an EKG at the time. Sometimes we do it with ultrasound. Sometimes we do it with a nuclear image of the heart too. Well, for the person without any symptoms of heart disease, no chest pain, no shortness of breath, no claudication or pain when they walk with their legs, well, we wouldn't screen for those patients generally, according to this Preventative Task Force service. However, there are certain societies, particularly a lot of cardiologists will recommend stress testing if you are greater than 45 and are going to start on a vigorous exercise program. And I'm not talking about walking 30 minutes a day or even light jogging. I'm talking about marathon training, triathlon training, those sorts of things. Some would say go ahead and get a stress test. But remember, every test that we talk about today, there are going to be false negatives, meaning that it missed a diagnosis, and there's going to be false positives, meaning it looked like the patient had a disease that they didn't have. And that sometimes leads to further testing that they may not need. So at this point, we don't recommend stress testing for the average person without any symptoms. I also see patients come in with the ultrasounds to their legs, looking for blocked arteries in the legs. The same holds true at this point. At this point, we have not proven that the evidence supports screening for asymptomatic patients. However, if patients have pain in their legs when they're walking, they cramp up when they walk, that could be a sign of decreased blood flow to the legs. So during the physical exam, we feel the pulses in the feet to look for that. And if I can feel the pulses, then generally I know that it's not significantly blocked. All right, hopefully I'm not going to make that noise all day. But what we like to do is counsel people on what they should be doing to keep healthy. So we're going to talk about exercise. And again, 30 minutes a day, brisk walking, just getting off the couch is important. You know, every time that you're up moving around, you're doing something good for your health. I like to call it, when it's been referred to in the past as NEAT activity, N-E-A-T, for basically non-exercise activity. T stands for thermogenesis or calorie burning. So NEAT activity is like what I'm doing. I'm not on the couch, I'm walking around. I'm on the phone, I'm walking around. I'm up doing laundry or doing yard work. That's not your classic exercise, but you're moving your body and your muscles through space. So that activity counts. It's important. Just getting off the couch. You don't have to go run to the gym to make your health better. So, walks down the street, walks in the house, doing those other manual things around your house all add up. For people that go to the gym and do 45 minutes to an hour of exercise and then come home and sit on the couch the rest of the day, that tends to take away a lot of the benefit that they accomplished while they were there. So these are what we talk about. One of the most important things we talk about is getting people to quit smoking, which has always been difficult, but thank goodness now we do have more options. We have a lot more education out there about the dangers of smoking, but we have medications now that help decrease cravings and the taste and the urge for cigarettes. We have over-the-counter now replacements that help replace the nicotine to prevent withdrawals. So this is one of my most important things that I address with patients is getting smoking stopped. And I understand that it's tough. And we have to assess the patient and try to determine, are they ready for change? Are they ready to make that step? And if not, we encourage it and then look again next time. And this sort of segues into my next topic. The guy sitting there says, Senator, I have the results of your colonoscopy. Senator says, and? He says, the voters are right. There are distinct traces of your head. So moving on to colorectal screenings, and these are the cancer screenings that I'm going to cover next. Colon cancer is recommended to be screened for after the age of 50. And it's usually done with a colonoscopy. And that's that long camera that we insert up the backside, look through all the colon after we've cleaned you out, and we're looking for polyps. We're looking for subtle signs of inflammation. We're looking for diverticulosis, but the most important thing is cancer that we're looking for here. And that's recommended if there's no polyps found and it's clean. You can do that every 10 years. There are other ways to screen for colon cancer, but I tell you, this has become more the common thing that we're doing now. It's fairly easy. There's a lot of facilities that do it, and the cost has come down. However, there are patients who choose to do stool cards every year. That screens for colon cancer too. It's not as good as doing a colonoscopy. Probably misses about 50% to 75% of cancers, but it does pick up some. And it has a lot of false positive too, because if we're looking for blood, and if you have gastritis or an ulcer, it might pick that up. So anyway, it's important just to think about getting these things screened. Also, you can do a flex sig with a shorter scope. Sometimes they'll do that with barium enemas too, to show the rest of the colon. It turns out most colon cancers are on the left side of the colon, and that's where the sigmoidoscopy reaches. But there's a whole other part of the colon that runs over here and down that they're missing. So take a few chances with that, and that would be every 5 years if you opted for that. But again, I think most physicians are recommending the 10-year colonoscopies at this point. Although I realize there are limitations to some patients' budgets or insurance reasons or just preferences. This is what the inside of a colon looks like when we do these scopes. This is healthy colon. The mucosal lining is nice and smooth and either a clear path, wide open, good healthy blood flow. This is what we might see with a polyp. And this is the scope coming in to actually take the polyp out. And this polyp here has probably been there about 9-10 years to get to this size. It usually takes at least 7 years before we start to see colon cancer growing. Too many mics, I think. Let me just move this one up a little bit, and I think it would be better. Good. Maybe not. Maybe if I stay over here.
Yeah, it's mine. Where's the receiver?
Oh, let's see. Let's see, this one.
All right.
Pardon the interruption. That's an obnoxious noise, I could imagine. This is something new, lung cancer screening. I was always told it didn't do any good to do lung cancer screening, but we always, in my office, would offer a chest x-ray in those patients who had smoked without really any evidence for or against doing that. And it turns out that chest x-rays probably are a horrible way of screening for lung cancer. It's very unlikely that they are to find one in an early manner where we could easily treat it. However, in the last year, the recommendation has been to start to use low-dose helical CAT scans of the chest annually, starting in patients at high risk for lung cancer. So, if you're a man between 55 and 74, or any patient, 55 to 74, that have smoked for 30 years, or 30 pack years, meaning a pack a day for 30 years, those patients should be screened now with that CT yearly, up to yearly. So, that's an important change. Lung cancer, now we screen for. Also, I've had patients say, well, I quit 15 years ago. Yeah, sure, I smoked 2 packs a day for 15 years, which would be 30 pack years. That's what we call it. That person, even though they quit 15 years before, ought to be screened again with these tests. And here's an example. On this x-ray here, this actually looks pretty normal. This is the heart. See, the aorta is the darker part right here moving behind, and you got all this area, looks nice and clear, a good healthy lung. So if we just did this on this patient, we'd say, everything's fine, nothing to worry about. Well, it turns out this same patient had the CT scan done, And sure enough, right there, that's a new, very early, very treatable lung cancer. Probably curable at this point. Now, if we're unsure what the spot is, sometimes we will offer biopsy. If it's too small, we may just say, okay, let's check a CAT scan 6 months down the road and let's see if it's growing. If it's big enough, maybe we'll do a PET scan. And a PET scan is a special type of test now that lights up cancer because cancer cells tend to metabolize faster than the other cells, particularly sugar. And we can inject some sort of radioactive sugar and see where it soaks up. And it tends to soak up in these cancer areas.
If you can just stand behind the podium.
Oh, okay.
And use that one, and I'll just turn this one off, and it'll stop doing that. And I'll try and fix it in the break. But yeah, if you just...
Okay. We're still good? Still hear me in the back? Okay. Now, here's a very controversial screening test. And it's, I guess, always been controversial, but there wasn't much debate in internal medicine in my area from residency on whether we should be doing prostate cancer screenings or not. The answer usually was, yes, you'd better go ahead and screen for it. However, I do remember a talk when I was in residency where a guy did get up and say, you know, we don't have any proof that picking up patients with PSAs early for the general population who's asymptomatic, that we make a big difference in overall public health by doing that. And we thought, that sounds silly. No, this has got to be a good thing, right? Picking up cancers when they're very small in the prostate. Well, now that we have more studies on prostate cancer and patients with prostate cancer long term, we know that some prostate cancers are very slow growing and will never lead to a shortening of a man's life. May never cause symptoms. So the PSA can pick up those cancers and perhaps get other testing done after that, like biopsies or removal of the prostate, and there are certain side effects of those things. The side effects that can happen with prostate biopsies are that anytime we put a little needle in that prostate, we can get bacteria start circulating in the blood. We call it septic. And I've seen several cases that turned septic just for the prostate biopsies. And perhaps that cancer was low grade and would never have really progressed in that patient's lifetime, depending on their age. Let's say prostate cancer was found at a very young age and was a very aggressive prostate cancer. Well, then it is probably right to go ahead and do a more aggressive procedures. Whereas somebody who's in their 70s or 80s, if they found it, maybe we should just let them live with it if it's a low-grade cancer. So right now, this task force does not recommend screening PSAs for any man of any age, nor do they recommend a prostate finger exam, which many of y'all are probably accustomed to. Now, that's not the way the urologists feel. It's not the way the American Cancer Society feels. At this point, they're still recommending that at age 50, we screen for these things. But what is universal is that we should have this conversation that tests can lead to further testing that might cause significant side effects. And even if the PSA was positive or elevated, and we said, well, let's just wait 3 months, 6 months down the road and repeat it again, well, that's going to be a lot of stress and anxiety and worry for that man. So these are the conversations that, as physicians, we are now having with patients to come up with what the patient feels and what we also feel is right for the patient. So it's more of a group effort in determining whether or not to screen for this. This is for the asymptomatic person who's not had any symptoms of prostate cancer. And symptoms of prostate cancer or straining with urination or pain with urination or blood in the urine, sometimes back pain if it's metastasized back there. But most men have no symptoms and it's picked up by these tests. But that's a conversation you need to have with your doctor. And I have this conversation every day now with men. Some have said, no thanks doc, I don't want to do it. Others have said, no, I'd like to keep doing it. However, if you're a male with a family history for prostate cancer, first degree relative, brother, father, then probably you should consider screening more than the average person. Or if you're African American, maybe you should consider screening more than the average person too. So again, that's a decision between you and your doctor now. But you don't have to feel guilty if you decide not to do it. This is really what we're feeling for when we do the exam. This is a side section, penis, testicles, bladder here. This is the rectum here, our finger goes in here, and we feel that back side of the prostate. We can't feel the front part. So that's why this exam doesn't always pick up prostate cancer. I mean, look, right there, you can't feel that. All I can feel is this right here. Now, if it's nice, smooth, soft, not enlarged, then I can say, I feel pretty confident you don't have prostate cancer. But sometimes we'll feel a little hard knot there, maybe like a BB, maybe something a little more irregular is hard. And those are the patients that you really got to think hard about biopsying or not biopsying, because a lot of those little knots that we feel are just calcium deposits or little stones in the prostate and aren't truly prostate cancer, but the risk of biopsy still carries the same risk. So again, it can cause a lot of stress and worry if I say, I found something on your prostate exam. Oh, by the way, your PSA happens to be normal, but I did feel something. So again, what do? The answer is right now we don't know for sure. Some doctors, a lot of doctors now are starting to do what they call active surveillance, which if a patient comes in, even with prostate cancer, they'll just start following them without taking out the prostate. They may see them every 6 months and follow it and see if it grows and do ultrasounds, maybe biopsy again down the road. But we're getting a little less aggressive with prostate cancer. Again, these things can change. They come and go in favor and out depending on what data is out there. Here's an example of what we would see with prostate cancer. Very early, you see it's kind of confined to one lobe, small. This is on both sides. Now it's starting to invade the capsule, and then it gets out of the capsule and starts spreading to the lymph nodes as a stage 4. Prognosis 1 and 2 would be a lot better, and depends on what type of cancer. Is it a high aggressive type of cancer, or very low cancer? Again, these are questions that the urologist would probably end up answering for me, because that's, if I see something abnormal, I usually refer to a urologist at that point. Skin cancer screening. Now, we're doing some skin cancer screening outside today, but this task force has not found a benefit for screening everybody with a full skin exam looking for melanoma at this point. I bring that up because that is kind of controversial. And we live in an area where there's a lot of sun, and I have a lot of patients who have multiple skin cancers. Most of them, the less aggressive types like basal cell and squamous cell, but some of those will be melanoma patients. And I'm going to show you kind of what melanoma looks like. But it is reasonable, and they do recommend that we recommend to patients not to get into tanning beds and to use sunscreen. So this is an example of what we might find. We use the ABCDs for skin cancer screening when patient, doctor decides to screen. Particularly, let's say you have a family history for melanoma. Okay, well, you're probably the person that needs to be screened, or a person who had multiple sunburns throughout their early childhood, as a lot of us did because we didn't use sunscreen back then. Normal mole, nice round, we call it, again, the ABCD, asymmetry. How asymmetrical is it? For instance, you can see on the left, the top mole is nice and round. We got here something that's very irregular, darker in the middle. It's not, if you split it down the middle, it's not equal. That's asymmetry. That mole needs to be looked at by a dermatologist. Look at this black mole. A lot of patients come in with these moles and say, well, I think I have melanoma. I said, well, it's nice, it's smooth, it's round, it's uniform in color. I don't think so. But this is more what we would expect. See, the border is very irregular. It's not nice and smooth and sharp like this. And then we're going to look at color. Same color throughout, or is it darker one area, lighter another area? And then we're going to look at the size of it. If it's greater than the size of a pencil eraser, I usually send those to a dermatologist for evaluation. So you can check yourself for moles later, and if you find anything that doesn't quite match up with these rules, then have your primary look at it or a dermatologist. The other thing that is recommended by this task force to screen for is depression. Depression is very common out there. A lot of stress in the world. We're all trying to push ourselves to the max, multitask every day, and we forget to do things that help us feel good in the meantime, and that can lead to depression. Family history for disorders of depression, that can get passed on. So, we screen our patients and ask them, over the last 2 weeks, have you felt down, depressed, or hopeless? And this is more than just, I feel a little sad for the last couple weeks. This is usually where it's starting to interfere with quality of life, and it doesn't seem to be something they can break out of. Or how, in the last 2 weeks, have you lost interest in things that you like to do? Most of my patients who are depressed have had these going on for a very long period of time and not realized that they were having depression. The reason we screen is because we have good treatments with relatively few side effects that can greatly enhance patients' quality of life and treat depression. If I treat depression, I usually treat it for about 6 months and then reassess the patient, and if they're doing very well, we look at tapering them off the medication. So it's not, here's your pill for depression, take it the rest of your life anymore. We have to reevaluate that every 6 months. But very common. Diabetes screening, as I mentioned earlier, is very important, especially if the blood pressure is higher than 135/80. So those are the patients, if we pick that up in the office, we're going to look for a sugar. Often, if you're going to a doctor and getting the annual labs done, usually that consists of a Chem 7, it's got sodium, potassium, your kidney function, sugars. We're often getting the cholesterol readings too. Every year we check cholesterol, certainly after the age of 50, but that should help pick up diabetes. We also could do a hemoglobin A1C test, and that gives us an idea of what the average sugar would be running over several months. And that is a number that usually runs about 5. 4 to 5 would be normal. If you get to above 6.5, that's what we call diabetes now. So that's 2 different ways of looking for diabetes. Now, these screening tests can still miss diabetes because the first problem that usually shows up in a diabetic is having an elevated sugar after they eat. So often they'll get excursions of their blood sugar really high after they eat, but it happens to return to normal by the next meal. If you just did a fasting blood sugar, sometimes you miss diabetes, maybe miss it by a couple of years until they start to have the fasting sugar. But right now, what is recommended is fasting sugar and or hemoglobin A1C. If a patient's very overweight, we're going to screen them. Over 45 is reasonable to do. Often, again, it's incorporated in routine blood work that's done in the office. Symptoms of diabetes, however, can be very vague. When it's very progressed, people come in and have a lot of excessive thirst, frequent urination. However, most of my patients that see me have had no symptoms whatsoever. They have often noticed that weight gain starts to occur several years before. Often it's difficult for them to lose weight because in type 2 diabetes, it's often that the body becomes resistant to the patient's own insulin that they're making in the pancreas. So that when you would eat something, particularly something with carbohydrates, then the pancreas releases insulin to lower that blood sugar. But when a person is insulin resistant, that insulin doesn't work as well. So the pancreas makes more insulin to get that sugar down. And it does great at that for about 20 years. That's what we call insulin resistance, and that's what we end up looking for in our clinics a lot of times, way ahead of time, and trying to predict patients' progression towards diabetes. There's maybe some evidence that if we intervene when patients are pre-diabetic, that we can prevent progression. And we had a diabetes prevention trial that was done, and the number 2 things that prevented progression of diabetes was regular exercise and lifestyle interventions. Diet that was in that study was along the lines of the Mediterranean style diet. Weight loss, 5%. That, just 5% body weight, with that exercise and the diet changes, prevented diabetes 50% of the time. Just those two things. And if we use a medication called metformin on top of those things, we might reduce it another 25%. But the most important thing is what you did with your lifestyle. Now, we'll change gears and move into vaccines, what's recommended. And everyone should get the flu shot every year unless they're allergic to eggs. Now, there are some formulations out now where the virus was not incubated in eggs, but most of the formulations out there do have the virus grown in eggs, and therefore people with severe egg allergy probably should not get this type of shot. Pneumonia shot is recommended for patients above the age of 65, and usually that's at least a one-time shot. So if you're otherwise healthy, one shot probably do you after 65. However, those patients at higher risk for pneumonias, patients with immune systems that don't work quite right, and diabetes is one of those things, and renal failure is one of those things, or kidney disease, or lung disease, or heart disease, those patients we would probably vaccinate every 5 years. If you've ever had a history of any cancer, pneumonia shots also recommended even before you're 65. And diabetics, we start before 65 with pneumonia shots and do those often every 5 years. So that's a very important one. Cigarette smokers, very important to get that too because you're more at risk for pneumonia. This prevents one type, but the most deadly type of pneumonia, well, way up there as far as deadly ones go, and that's strep pneumonia. That's different than what causes strep throat. That's a whole different type of bacteria. This is one that I get all the time. Patients say, how about that shingle shot? We call it Zostavax. That's one brand of this type of shot. And I'm going to show you some pretty impressive pictures of shingles in a second. But basically, if you're 60 years or older, ask your doctor about the shingles shot. Because up to a third of older adults will get shingles at some point. Now, sometimes shingles is very mild. Some people don't even come to a doctor. They think they just had a little allergic reaction to poison ivy or something like that. It's not a bother. However, other patients can get very ill with shingles, and it can lead to permanent nerve damage with chronic, searing, burning, daily, consistent pain. So this vaccine tends to lower the risk by 50%. So we are recommending this shot now. Here's an example of a local skin reaction, and what we'll see, there's these little blisters right here, all throughout. Some of these have popped already. Shingles is basically the same virus that causes chickenpox when you were a kid. When you got chickenpox, that virus affected you at that time and then became dormant and starts to live out in the spinal canal. Then later, as you get older, maybe you get very stressed or you get some physical illness that allows this virus then to not be suppressed, and it comes out through nerves from the spine and shows up on the skin. And usually it occurs in one nerve area. Not always. Usually it's only on one side of the body, rarely on both sides, although I've seen exceptions to that. This would be an example of, see, again, it's kind of in one strip on this patient's chest wall, grouping of blisters, and it can have a lot of different appearances. Sometimes it's hard to determine if it's poison ivy or allergic skin conditions. If it's very early, it's nice when they come in as blistery and crusty and looks really ugly and it burns, but it doesn't always do that. Sometimes we just have to have a high suspicion. I've even seen patients come in with chest pain, didn't have a rash at all. If they're having chest pain, I said, well, we'll do these things to make sure it's not heart disease or something going on with the lungs. But if you happen to get a rash in a couple of days, it could be shingles. Lo and behold, every once in a while you'll see a patient call and say, yep, I got that rash. Then you're like, okay, not life-threatening, but we're going to treat it. This is really what we're afraid of when it involves the face and the eye, tip of the nose right here. That's one of the signs that we look for. If somebody comes in with shingles, if they have it in their ear, we'll look for a sign of tip on their nose, because if it's on the tip of the nose, it's very high risk for invading the eye and causing permanent scarring and blindness. So I always look for that little crusting lesion on the nose. And I usually have an eye doctor see them if it's involving this area of the face. But again, looks very horrible. And this patient is probably going to be left with long-term burning pain, which will require medication just to suppress that. So again, we want to try to prevent that. That vaccine is important. Also, hepatitis B vaccine is recommended for patients with certain risk factors. So if you happen to work in a healthcare field where you're going to be around blood and body fluids, it would be worth getting the vaccination with the hepatitis B series. If you've been exposed to somebody with hepatitis, it's worth getting this vaccine. So again, it's not for everybody, but it's for patients that have these occupational exposures, first responders, that sort of thing. Also, if you already have hepatitis C, which is a different virus, that can cause scarring and cirrhosis. We wouldn't want you to get hepatitis B on top of that, so we would give you that vaccine to prevent it. Tetanus, of course, every 10 years. And one time we will give you the Tdap, which is pertussis, which is whooping cough. Whooping cough is starting to come back again. It had gone away for a long time. We are seeing it again, and it's not unusual now. So we're recommending at least one of these boosters be the one with the pertussis in it. So tetanus with pertussis at least once, but every 10 years you get that. Bone fractures, we're asking about your risk for falls. We might check vitamin D. If it's low, we replace that. That's been shown to reduce falls in elderly patients. So we're going to ask about these things. We may do a bone density on you. Let's talk about risk factors. If you've been sedentary many years, you smoke, you got a strong family history for bone fractures, these patients should definitely get a bone density test after the age of 65. How much calcium do you take? Right now, we don't know what to recommend with calcium. We should recommend it for everybody, really high doses. And then there's some studies that came out of Australia that said, well, wait, hold on. Maybe too much calcium is going to cause calcium buildup in the heart arteries, and perhaps we do see an increased risk of heart attack. So, I prefer my patients to get their calcium through foods. Now, if they don't eat much dairy or cheese or drink milk that has calcium in it, well, then we'll probably have to supplement in those patients with thin bones. But we just don't recommend blanket calcium for everybody anymore. We're going to talk about obesity. Again, exercise, weight loss. Pass out those things on our weight loss program. It's a meal replacement program that helps people cut calories without having to think much about the foods that they're eating initially. And we train them on how to work back into a regular diet and keep it off long term. We'll also do some sexually transmitted disease screenings. We'll ask about alcohol and tobacco or other drugs. And we'll do a whisper test where we whisper in the office. If you can't hear it, we'll get a hearing test. We want everybody to see an eye doctor, particularly after the age of 60, look for glaucoma.